Dr. Rohit Om Prakash.
None of the authors have any financial disclosure in the subject matter of the film. Present-day cataract surgery is fast becoming a refractive procedure, with the aim to have no refractive surprises. However, we all have unhappy patients due to various factors. Advancements in biometry and IOLs, along with the newer generation formulas that incorporate several variables, allow us to achieve a 20/20 happy patient. Of the reasons for refractive surprise postoperatively, capsular bag distension remains as a major concern despite the low incidence. We observed a change in effective lens position and a resultant refractive surprise along with posterior capsular bowing or occasionally posterior capsule wrinkling in such cases in our setup. One of the proposed mechanisms is lifting of the IOL due to fluid entrapment during stromal hydration. This surgical video with intraoperative OCT shows how the capsular bag distends while doing stromal hydration. In such cases, YAG laser anterior capsular opening adjacent to the optic edge allows fluid to egress and settles the IOL. However, an ounce of prevention is better than a pound of cure. We designed a new IOL. This IOL is a single-piece aspheric acrylic hydrophobic lens with an overall diameter of 13 mm and an optic diameter of 6 mm. There are 4 unique fenestrations placed equidistantly in the optic periphery, with each hole being 500 microns in diameter. The surgical video during OVD aspiration shows how easily the OVD comes out through these fenestrations from all 4 quadrants. Intraoperative OCT reveals close approximation of the IOL with the posterior capsule even during stromal hydration. When we looked at other IOLs, there was a space between the IOL and the posterior capsule. Maneuver to depress the IOL in the bag may or may not release the fluid in these cases. A recent study on intraoperative OCT revealed contact between IOL optic and posterior capsule occurred rarely at the end of surgery. On analyzing surgical videos and intraoperative OCT in various IOLs, there was a mild to moderate degree of capsular bag distension seen. Surgical animation shows how the OVD egresses out from these holes, allowing the IOL to approximate with the posterior capsule. We did a pilot study on 100 IOLs designed with fenestrations. Outcome measures studied included presence or absence of capsular bag distension, IOL rotational stability, effective lens position, PC wrinkling or PCO. This representational case shows IOL attaches to the posterior capsule that prevents capsular bag distension, maintaining the effective lens position and thus allowing rotational stability over 6 months follow-up. We observed a stable ELP as the aqueous depth on IOL Master 700 remained same over 6 months. The change in MRSE was 0.02 demonstrating refractive stability. All the IOLs were within 5 degrees of rotation. Literature reveals greatest misalignment occurs during first hour after surgery. Therefore, we used Callisto Eye platform intraoperatively to mark the axis of placement of holes, which was validated post-operatively using OPT3 scan. This new IOL with 4 holes is implanted with a routine procedure and does not require any special instruments or technique. With this new lens, there is no need to go behind the IOL to remove the OVD, curtailing the risk of posterior capsule rupture. This IOL achieves immediate intraoperative stability. Over 6 months of our study, there is a rotational stability in all cases that is crucial in toric IOLs. This IOL prevents capsular bag distension in early postoperative period, thus allowing stable ELP and hence no postoperative refractive surprise. Additionally, there is no posterior capsule wrinkling seen that can prevent abrasions. Evolving from PMMA IOLs to acrylic IOLs, we removed the holes. However, the holes of PMMA IOLs, as seen in this case, possibly allow prevention of CVD and thus minimal or no posterior capsule opacification. For the new IOL, long-term evaluation and future prospective trials are necessary to validate the fact that these can decrease the rate of posterior capsule opacification. In the present pilot study, no patient complained of dysphotopsia till 6 months postoperatively. Nevertheless, to rule out this possibility, prospective study is being carried out on IOLs with 325 micron diameter holes. With this IOL, we observed no CVD, a stable ELP, and desirable rotational stability. There was no PC wrinkling or PCO seen over 6 months. Now is the time to recreate. Thank you.
Thank you very much. Few things, the videos were very good.
Thank you, sir.
Certainly very good, and analysis also was good. I just wanted to know what exactly is the design of this lens. I mean, is it biconvex, plano-convex, anterior, posterior, or there is no, it's just a flat this thing. And is there any angulation?
So it is it's the same lens that we use. It's an aspheric hydrophobic lens with a biconvex structure. It's actually we can incorporate these holes in any kind of lens.
No,
so,
that's not the point which I just want to know what kind of a lens, whatever you have designed.
This one was a biconvex, square-edged.
Biconvex with 360 degree square edge.
Yes, sir.
And if it is a biconvex lens, would you think that posterior curvature would touch the posterior capsule, but in between the 360 degree square edge and all that, the fluid will still be there?
So in fact, the lens that we implant in the eye would be a very thin lens. It wouldn't really matter if it is a biconvex or a planar convex. But what matters really is that the PC in the center, or at least until the mid-periphery, should be attached to the optic of the IOL. Even with the other lenses like Technis and the other Nidec and other lenses.
And finally, last thing, I mean, yes. Washing behind the lens, going behind and doing a procedure is, I think, carried out by almost all the surgeons as a routine thing.
Absolutely.
And we really don't observe kind of PCR
So
at that point of a time. Once in a while, maybe, but
Correct.
that's extremely rare. So for that perspective, if you are thinking that This,
So it's one of those aspects which can really be taken care of. It's not just the only aspect. It's one of those aspects which can also, because as novice surgeons or as experienced surgeons, in experienced hands it wouldn't matter, but in novice surgeons there can be a possibility of PCR when we go behind the IOL and lift it up. We can actually tear the capsule if the irrigation port is not upwards. So despite that, like you said, in experienced hands it wouldn't matter, but it's just one of those aspects which can also be taken care of if we have the holes.
and finally, I think you showed that with a PMMA lens with 2 holes, there wasn't any problem as well.
This was
So,
the
I mean, why did you design 4 holes?
Correct, sir. So this we designed because when we sat over in our ethical and research committee, we thought that each quadrant should be taken care of. So there shouldn't be any particular axis of placement of the IOL which would take care of the capsular bag distension or the rotational stability. Because we did see that in certain cases there was just inferior distension of the bag post-operatively in the cases which were not having the holes. So at times we can just have inferior distension of the bag even if it's not a complete distension. So the gravity can affect the placement of the IOL.
No.
So we just wanted all the 4 quadrants to be taken care of.
My question was with 2 holes in PMMA, you did find the similar
So
kind
that
of...
was that was the case which was 30 years old, and in those times the rexes, the anterior capsular rexes was very, very big in size. Those days, either we used to do extra capsular or we used to do can opener kind of rexes. So this was one with the smaller rexes.
You have made the hole exactly on the periphery.
Yes, sir.
So how much it's going to make a difference? Because it's just periphery, and about within half a millimeter it is a full open field. So if capsule is going to block that edge, it can block at that, it will rest at the edge of that hole only.
So the optic size is 6 mm.
It is not going to cover your central area, just like we have ICL in that central
Correct.
hole.
So this was just a pilot study that we did, and what we've done is we have taken an optic size of 6 mm, keeping the hole size of 500 microns. So if we add up the dimensions of both the holes from right and left, it would be 1 mm. So ideally speaking, it is already 1 mm inside of the desired area of the rexus margin.
This is 6 mm optics?
Yes.
So you are come
So-
1 mm inside.
So it is 500 microns inside of the edge, which is already 1 mm,
Then
and
it is
then
going
the
to-
holes are already 1 mm. So we did a study to see if there were any dysphotopsias because of this. None of the cases had any overriding of the capsular rexus margin. We are also trying to do it on 325 microns, and we do intend to have something like a centraflow in future if we can develop for IOLs as well.
Thank you.
Thank you very much.
Thank you so much, sir. Surely, sir.
Do you think that it is easier to remove the OVDs from these holes? I think even if you're putting these four-hole IOL, you'll have to go behind the lens and remove the OVD.
Safe.
That is safer, number one. And number two, when you're talking about the stromal hydration, you should do stromal hydration.
Correct.
Yeah. So if you're doing a stromal hydration, it does not mean that you overinflate the anterior chamber always.
So for the first question, like we already see that in centraflow, even if it's just one hole, we don't have to go behind the ICL and take out the OVD. Even if we keep it inside, it just gets egressed out.
Because
Here-
we cannot go inside
Absolutely.
behind, because you have the clear lens in the central fold.
Absolutely,
Here
sir.
it can very
No, you
easily
can go behind the lens even, sir. You can, in ICL, you can go behind the lens
but
and
we
do
still,
it.
No,
we,
for ICL.
Yeah, even for ICL, yes.
right.
Yes.
So
you
in
can
these
go.
cases, the literature has proven that 84% of the patients intraoperatively, in those in whom we've implanted the IOL, there is some amount of capsular bag distension. This is an article from JCRS which was published in 2016, which states that 84% of the patients do have some amount of capsular bag distension. And there is an article also by Dr. Chang which says that there is an IOL rotation in the first hour of the surgery that happens because of the retained viscoelastic, even if we go behind the IOL and take it out. So these holes, even after we have taken out all the viscoelastic from behind, even if in these cases also we can go easily behind the IOL. But our intent is not just to take out the viscoelastic, which can cause osmotic pressure and attract the
Got
fluid.
your point, yeah.
It's also
Okay.
for any kind of fluid that can go behind.
Thank you so
Shruti,
much.
thank
And,
you.
The
That
video
was
was
a
so
good
nice
research
that
effort.
it has initiated so much of discussion. But
Thank
because
you.
of want of time,
Thank you so
we can't
much.
take it Interesting. further.